So today I'm going to brush up on just what, when, why, where, and who, and how fertility preservation in cancer patient, mainly focusing on the embryological aspects. So as in continuation with Dr. Snehal's slide, so we all know that the survival rate has already improved. So with nowadays increase in the reproductive age group and the childhood cancer increasing, at the same time, the survival rate is also increasing. So that is because of the early detection with the sophisticated diagnosis and treatment modalities, the survival rate has improved. So we are now focusing on not just the survival, it's the survival and the quality of life. So we know that the cancer and the cancer treatment has a deleterious effect on the reproductive health. So the long-term side effects are premature gonadal failure, that is infertility. In male, it can impair spermatogenesis and has a negative impact on the semen parameters. It can result in transient oligospermia, transient azoospermia, or it can cause a irreversible azoospermia. Whereas in female, it can lead to amenorrhea, anovulation, atresia, or poor quality eggs, resulting in a negative impact on the fertilization and implantation. So before the cancer treatment, it is important to estimate the risk of fertility. So pre-treatment factors includes reproductive and obstetric history, history of sexual transmitted diseases, history of surgery or trauma to reproductive organs, family history of infertility, and underlying medical condition that could result in infertility. So following this, hormonal evaluation like AMH, FSH, LH, estradiol in case of women, in case of men, testosterone, and inhibin B level should be done to assess the fertility function. Fertility risk assessment tool is nowadays available online to generate an individualized risk assessment based on the age, cancer diagnosis, treatment, and fertility and future fertility goals. Gonadotoxic risks can be stratified into 4 categories. Either it can be no risk, low risk, intermediate risk, or high risk. So according to the European Society of Medical Oncology, they have recommended the following. All patients of the reproductive age group should have a complete oncofertility counseling as early as possible, that is even before the treatment is being planned. And the counseling should be individualized. During the counseling, the medical health professional and the genetic counselor should be available. Written information or the online resources should be provided to the patient. Those patients who have the potential interest in fertility preservation should be referred immediately to the fertility specialist team. And since there is no threshold of the toxicity, every patient should be considered as that they are at a potential risk of developing treatment-related gonadotoxicity. So what is fertility preservation? So here we tend to protect the gamete, the egg or the sperm or the embryo or the tissue, so that the person can use them to have their own biological children in future. So this is our unit where the treating center should have well-equipped and also with a highly specialized team consisting of oncologist, gynecologist, reproductive biologist, transplantation surgeon, and research scientist. So we should have a cryopreservation unit. This is the laminar airflow where we tend to screen the oocytes. And the oocytes are cultured in the incubators for almost 5 days. And we have the micromanipulator to do IVF and the ICSI procedure, and laser-assisted hatching and pregenital for embryo biopsy for PGT. So fertility preservation strategies may not be suitable for all. So the success rate of a fertility preservation option depends on the patient age, health condition, that is the type and the spread of disease, type and the dosage of cancer treatment, time available, and whether she has a partner. Fertility preservation in female. The established ones are the gonadal shielding, ovarian transposition, oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation. The investigational are GnRH analog, in vitro activation, in vitro maturation, and transplantation. Whereas in males, established ones are gonadal shielding, gonadal transposition, semen or sperm cryopreservation. In investigational, we have GnRH analog or testicular tissue or spermatogonial stem cell cryopreservation. So we will look into the fertility preservation strategies in female, where the first thing is gonadal shielding. It's done in mostly in the radiation therapy to reduce the dose of radiation delivered to the reproductive organ. But the limitation are possible with selected radiation field and anatomy. Experts are required to ensure shielding does not increase dose delivered to the reproductive organs, and gonadal shielding cannot be used in the combination therapies. Ovarian transposition. Ovaries are, in this case, mobilized from the field of radiation to protect the ovarian function. The latest one is the laparoscopic modification, where the ovaries are temporarily affixed to the anterior abdominal wall. But the only disadvantage of this is due to the stretching of the ovaries, the fallopian tube might get damaged. In that case, the option natural is not possible. Natural conception is not possible. They have to go for a IVF treatment. But in this ovarian transposition, pregnancies have been achieved even without surgical repositioning. So egg cryopreservation. So this is recommended for unmarried and those patients who do not have partner, or in the patient who have ethical or religious objections to embryo storage. So it's highly recommended that they have a fair chance of good ovarian reserve, and the medical condition allows controlled ovarian stimulation and oocyte retrieval. So in egg cryopreservation, what we do is we tend to stimulate the ovaries. Once the follicles are of appropriate size, the egg retrieval is done and they are frozen. It looks simple, but it's not the same, because it's oocyte cryopreservation is technically challenging because of two reasons. One, we tend to get a different cohort of oocytes. That is, we tend to get a mature oocyte and the immature one. Mature is the metaphase 2 stage oocytes, whereas the immature ones are GV and metaphase 1 oocytes. And the second challenging thing is the oocytes has a large cytoplasm, unlike the embryos and the sperm. So the water content is more. So during freezing, the cryo injury is more because of the ice crystal formation. And also the drawback in oocyte freezing is in M2 stage, there is an extremely sensitive they are extremely sensitive to temperature, and presence of the mitotic spindle, zona hardening occurs, and there is a premature release of cortical granules. Whereas in GV stage, since there is no spindle fiber, chromosomes are protected within the nuclear membrane, but still the survival and the maturation rate is much lower. Embryo cryopreservation. This is a very established technique which has a very good success rate, and patients who have partner and have the time to delay the therapy can go for embryo cryopreservation. Here again, the follicles are stimulated, the oocytes are retrieved once we get an appropriate size of the follicle, and this is followed by either IVF, in vitro fertilization, or ICSI, intracytoplasmic sperm injection. Here, we tend to inject the sperm directly into the egg. So once this is done, the next day. So basically 5 days, the embryos will be cultured in the incubator. So the day 0, we do ICSI, and day 1, we check for the fertilization. And day 2, it should progress to either 2-cell stage or 4-cell stage. On day 3, it's anywhere between 6 to 8-cell stage. And day 4, it's morula, and day 5 is the blastocyst. So embryo freezing can be done either on day 3, that is on 6 to 8-cell stage, or it can be done in day 5 blastocyst. So we generally prefer a day 3 freezing rather than day 5. The reason is In day 3 freezing, we can have multiple attempts, whereas in day 5, there is a limited number of attempts. And also, in case those patients who have a familial history of genetic disorder who wanted to do PGD testing. So in that case, blastocyst is preferred because we get more number of cells for embryo biopsy and we can send it for testing. Pre-implantation genetic testing. Again, the embryo biopsy can be done in a day 3 stage embryo or in blastocyst. But we prefer to do it in blastocyst because we get more number of cells, and even the genetic lab prefers to have more number of cells rather than 2 cells. And also there is an increase in case of day 3, we tend to biopsy only 2 cells. So very less number of cells, and there are also high chances of mosaicism. And once the biopsy is done, we tube them and send it for genetic testing. So usually PGT is done to allow the detection of cancer genes, especially BRCA1, BRCA2, in case of familial adenomatous polyposis. So in these cases, we tend to do PGT, and only those which are euploid or normal embryos are transferred. Basically, freezing itself can have a deleterious effect on the oocyte, embryo, or sperm. That's because of 2 reasons. One, there can be ice crystal formation. That's cause the cryo injury. Usually the cells can undergo physical, mechanical, chemical, or osmotic stress. So that's the reason we tend to add this cryoprotectant, which are nothing but the permeating and the non-permeating agents. So that helps in dehydrating the cell and also to lower the freezing point of the cells. So main method which we follow is vitrification in case of egg and the embryo freezing, but whereas rapid freezing, we use it for the sperm. Slow freezing, we do not go ahead. That's only reason is we need a sophisticated chamber for it, and it takes a very long time for the freezing to happen. And the device usually which we prefer is, in case of sperm, we use the straws or the cryovial, whereas in case of embryos, we use a cryolox or cryotip. So usually we go for a vitrification where the oocytes are subjected to different concentration, a higher molar concentration of solutes, and then they are plunged into the liquid nitrogen, which is almost minus 196 degrees. And once, in case later, if you want to retrieve them, they are thawed back. Where they are subjected to thawing solution, diluting solution, and wash solution, and then they are transferred. Ovarian tissue cryopreservation. This is an option for prepubertal girls. The extraction, we require very less, half the ovary may be sufficient, that is 20 to 30%. Here, once the ovary is retrieved, the corticals are dissected and they have made into very thin strip, probably not more than 2 millimeter. And they are taken in a steel rod kind of thing, and they are placed and plunged into the liquid nitrogen. And later, whenever we require, we are thawed them with different medias and they are transplanted. Or another option is we can go for in vitro maturation, but the success rate is much lower. So they prefer transplantation. Now, ovarian tissue cryopreservation has come under it's not the experimental label now. So it is an established protocol. The reason is almost we have got 130 live births have been reported in 2017, and the success rate of the live birth is almost 20 to 30%. And in each case, the hormonal production has also been restored for up to 12 years, that is average of 2 to 5 years. And there is one study which has reported that in 18 patients where they had been frozen, between 9 to 20 years girls have those tissues have been cryopreserved and auto-transplanted later, have resulted in 10 live births for almost 9 mothers. So ovarian tissue cryopreservation should be carried in centers where there is a clinical expertise with IRB approved protocols that includes a follow-up for recurrent cancer and in patients with increased risk of infertility. And the success rate depends on careful selection of the patients, surgical expertise, and laboratory facilities. The advantage of OTC is we need not delay the cancer treatment. It avoids the risk of ovarian stimulation, no need of partner or the donor sperm, preserve larger pool of follicles and allow for the resumption of ovarian follicles. Ovarian function resumes between 6 to 240 days post-transplant and lasts up to 7 years, and the only technique available for prepubertal girls. The limitation is possibility of reseeding of cancer cells, resulting in cancer recurrence. So this is the result of ART in the fertility preservation. This is a almost recent study from Fertility 2017, where they have showed with embryo cryopreservation, the live birth rate per ET is almost ranging between 22%, here 45%, whereas oocyte vitrification, though not in the cancer patients, the live birth rate is pretty good, that is 22 to 50%. And ovarian tissue cryopreservation, which was done in almost 111 cases, 32 patients have conceived with 29% live birth rate per patient. So moving on to the experimental or the investigational procedures, GnRH analog. So this is used in prepubertal girls. Here there is a suppression of gonadotrophin levels and this GnRH decrease the ovarian perfusion, but there are still insufficient evidences to support the same. But if GnRH administration has to be started, it should begin at least 10 days prior to chemotherapy because of the initial flare-up effect, and should continue till 2 weeks after the end of the chemotherapy. And in case of estrogen-sensitive tumors, tamoxifen therapy can be initiated after the GnRH analog treatment. Autotransplantation, this is one of the successful treatment. After ovarian tissue cryopreservation, those tissues can be transplanted back. So it is either by orthotrophic autotransplantation or heterotrophic autotransplantation. Both the technique had given a successful pregnancy. In vitro maturation, where in those cohort we get immature eggs, they are subject to IVM, in vitro maturation media, which has gonadotrophins, nutrients, proteins, and growth factor. So we culture them almost for 2 days, almost 36 hours, and then we tend to check them whether it has progressed to metaphase 2 stage. Only then we can go ahead with the fertility treatment. So, but the implantation rate of IVM are low, between 10 to 15%. This is relatively newer technique. This is the in vitro follicular activation, but this concept has been carried out in patients with premature ovarian insufficiency. Here, the concept states that the primordial follicle, which is of a larger population and mostly quiescent, they are activated. Every cycle they get activated, a few undergo the selection, and only one dominant follicle progresses. This is because of the balance between the AKT signaling pathway and the hyposignaling pathway. But if there is a disruption in the hyposignaling pathway, they show that there is an activation of the primordial follicle. So what they have done is ovarian tissues were removed and fragmented. This fragmentation has caused disruption to the hyposignaling pathway. So in turn, it has activated the AKT signaling. So, and also they have subjected them in IVA, in vitro activation media, which containing phosphatase, angiotensin, homolog, and inhibitors, and PI3K stimulators. And they have seen there is a promotion, the growth of the primordial follicle has gone to preantral follicle. So this study has been done in premature ovarian insufficiency, and live birth has also been resulted. So this can actually be extrapolated into the cancer patient also, and those patients where the elderly patients who require their own biological kit, or in those patients, pubertal females where we had frozen the ovarian tissues. Moving on to the fertility preservation strategy in male. So one which is the gonadal shielding. So there is a physical gonadal shielding and chemical gonadal shielding, but chemical one is still in the experimental thing. Physical gonadal shielding, this is used to minimize the scatter radiation to the testis in both adult and children. The sperm cryopreservation, this is the most effective and efficient method. This is recommended before initiation of the cancer treatment, especially in the post-pubertal and adult males. Before cryopreservation, all men has to undergo infection screening and semen analysis. And usually we recommend 1 to 3 samples with a gap of 3 to 4 days of abstinence. Surgical sperm retrieval techniques. So in case of difficulty in sample procurement or in severe oligospermia or azoospermia, there are 2 options. One is epididymal aspiration or the testicular aspiration. So it can be testicular extraction, or microTSA can also be done. In case of testicular tissue, we tend to, there will be, the biopsy tissues are usually handed over. We subject them into the culture media, and all these seminiferous tubules are teased, and the sperms are released, and the sperms are then centrifuged and frozen in multiple vials. The success rate with the thawed sperm, usually in case if they later want to undergo IUI, fresh semen is better in IUI procedure rather than the frozen thawed semen IUI. But whereas for IVF ICSI, there is no difference in the fertilization and the pregnancy rate between the fresh and the frozen thawed semen sample. Fertility preservation strategies in prepubertal boys. This is the testicular tissue cryopreservation. Again, this is the experimental one where live birth rate has not been achieved till date. Here, testicular tissue cryopreservation is the only option for prepubertal male. Even neonatal testicular tissue possesses the spermatogonial stem cells. So either they can be frozen as a cell suspension or as a testicular tissue. So in males, the recommended option is the sperm cryopreservation. So regarding the documentation and storage, usually all the samples are labeled, and we have a return as well as a computerized inventory system. And since all sperm, egg, and embryos, once they have been in the frozen state, they are in the dormant state. So we can preserve them for decades, but the Indian guidelines doesn't allow that. So, but they haven't at the same time not mentioned like how long or how long duration we can preserve them. But the statutory maximum time period for storage for medical reason is 55 years in case of male and 50 years for female. Every year renewal in terms of payment as maintenance cost, which is valid for 1 year. Legal and ethical issues. So the concern form should have a provision for disposition of the frozen samples in the event of death. So either it can be discarded or use of concern to use it to the partners or third-party donation. In case of minor or prepubertal fertility preservation, parental consent and assent should be taken. Collection of the semen should be counseled before. Legal control at the time of maturity has to be mentioned. And they all should be tested for communicable disease. Testing should be done. And discard consent policies should also be there in long-term freezing. When the client no longer desires to use the stored embryo or donor relinquished rights to specimen that are donated, provision for discard of specimen in case of non-payment of storage fees. So these all things should be addressed in the concern form. Lastly, restoration. Once they have preserved all the gametes and later once they want to restore the fertility, they can, in case of embryo freezing, they can undergo embryo transfer. In case of oocyte freezing, ICSI followed by the embryo transfer. In case of ovarian tissue cryopreservation, either it can be natural with in vitro follicular activation, or they can go for autotransplantation again, followed by IVF and ICSI. In vitro maturation can also be done, but again, the rate of the success rate is almost less. But during the cancer treatment, it's all the patient should be counseled of the contraception, and it was also recommended to continue the contraception 3 to 6 months post cancer treatment, and before starting on the fertility treatment or when they plan for pregnancy, they have to be assessed for fertility function, mainly the gonadal markers. And this is the same with males also. The recommended waiting period is 9 to 12 months, but even after that, it doesn't guarantee that there would be sperm production. But before going on planning for pregnancy or for any ART treatments, semen analysis and sperm DNA fragmentation should be done. To summarize, cancer may have a negative effect on male and female reproductive health through multiple pathophysiological mechanisms. Radiation and chemotherapy exhibits dose-dependent gonadotoxicity. Fertility preservation should be discussed with all patients of childhood stage or the reproductive age group. Rising pregnancy rate of sperm cryopreservation, oocyte cryopreservation, live birth after transplantation of human ovarian tissue have shown a promising future in the field of fertility preservation. Adjuvant procedures should be employed when appropriate. Innovative and possibly revolutionary technologies for fertility preservation are currently in development. Once established, may change our current approaches to fertility preservation in cancer patients forever. Thank you. So I think without any delay, we will start on with the panel discussion. I call upon Dr. Snehal to start this.
Thank you, Sangeetha. So